Good evening, everyone, and welcome to another episode of Health is the Ultimate Wealth. We, as always, come to you every Saturday evening between 5:30 and 6:30 p.m. We have a very interesting topic today, something that almost every adult woman at some point or the other has experienced in her life, either irregular period, which is defined as a period that is too long, too short, or irregular bleeding with that period, either too much bleeding or too little. The causes for this are very varied, manifold, and are not necessarily problems that are only related to the uterus as such, but can be problems that originate elsewhere in the body and are affecting the uterus. To talk about this, we have Dr. Souptik Ganguly. He is one of the rising stars at Medica. He's a gynecologist here at Medica, and without any further ado, we let Dr. Ganguly take over and talk to us about irregular bleeding, irregular periods and bleeding. Dr. Ganguly.
Thank you for the introduction. Good evening to everyone. Today, the topic of discussion will be the bleeding, the abnormal uterine bleeding, and abnormal uterine bleeding. Something we also represent as irregular bleeding or AUB. Sometimes we say, and any bleeding which deviates from the menstrual pattern is known as abnormal uterine bleeding. That bleeding can be more, as it was just mentioned by Dr. Aviral, that the bleeding can be more, the bleeding can be less, and sometimes it is unscheduled bleeding. So initially, I'd like to mention that it is the common presenting symptom in OPD, in gynecological OPD. And it is also the most common reason for hysterectomy. And the majority of women comes in OPD with these symptoms that there is some irregular bleeding. But in majority of cases, many of them are not aware of the normal pattern or what is the normal variation as per age or as per different circumstances or different periods of life. So the identification of the normal pattern of bleeding is very important. So the presentation which I will be talking about today will deal with a stepwise pattern. So initially, the normal menstrual pattern, I will be highlighting a few points. Then few points are how to identify any abnormal bleeding or when to raise an alarm or when one should meet a medical professional or a doctor for an abnormal bleeding. And then I would like to highlight some of the common causes of the irregular bleeding and the relevant investigations and how to manage those problems and whether initial medical management or which cases which will require surgery or surgery which will the conservative surgery, uterus preserving, or when we will remove the uterus. So initially I will come the normal menstrual pattern. So normal menstrual pattern is the cycle length is usually between 24 to 38 days. And any bleeding between, if the cycle is 30 days, that is also normal. And if the cycle is 36 days, that is also normal. Some of the guidelines mention that it must be between 21 to 35 days, but overall, we say that it is between 24 to 38 days. And the flow duration is between 4 to 8 days. So even 6 days is normal, 8 days is also normal, and also 4 days is also normal. And volume, I will mention it later, that what is the volume of the menstrual blood is 5 to 80 ml per cycle is normal. Regularity that means there is no absent menstrual episodes. That means in a year you are having irregular periods and there is not a month or two that you are having no periods. If you are having this type of symptoms that in a year 3 or 4 months you are not having periods, that is abnormal. Every month if there is periods at a specific date or the cycle length, as I mentioned before, between 24 to 38 days, it is normal. So, how to identify normal menstrual bleeding? It is not obvious every time. It is not possible to measure the amount of blood, but obviously, grossly, it needs around 4 to 6 pads in a day, and there is no passage of clots, and it is non-clotted fluid blood, and it is not associated with any anemia. Like some of the women complains of that there is some heavy bleeding as per them, but the hemoglobin is within normal limits, even on repeated examination, even on repeated laboratory evaluation. That means that either she is not perceiving or she is perceiving it as heavy bleeding, but actually it is not. So it must be associated with anemia. No, maybe not in the initial cycles, but if the bleeding is persistent, then is needs to be got associated with anemia. If there is no anemia and even there is complaint of heavy bleeding for a long 5 months, 6 months, then repeat evaluation or proper history and proper this evaluation needs to be done, whether there is really any excess bleeding or present or not. So as I mentioned that when to seek a medical attention. So as I was telling before only, the menstruation we can divide in a four categories of the criteria. What is the frequency, and it is regular or not, and it is duration of the bleeding and the volume. And frequency, it is as I mentioned before only that it is grossly it is 24 to 38 days, but some of the text guidelines also mention it as 21 to 35 days. So frequent menstruation, we give a medical term as a polymenorrhea. So here it is, if it is menstruation is happening less than 24 days or sometimes it's 21 days. And infrequent means the menstruation is getting delayed. That is, it is happening more than 38 days cycle length. Regular is the days variation is less than 20 days, and irregular it is more than 20 days variation. Duration, it is as I mentioned before also, it is normal if you are having bleeding 4 to 8 days in a cycle. Prolonged bleeding, it is more than 8 days, and shortened bleeding, it is less than 8 days. Volume, it is mentioned before only that it is 5 to 80 ml. All of these are normal, and exact measurement may not be possible in every cycle. But as I mentioned, that it is if the required around 4 to 6 pairs and there is no clots, no anemia, you can be assured that menstruation is normal. But if it is more than 80 ml, they call it as menorrhagia, and if it is less than 5 ml, we say it is hypomenorrhea or oligomenorrhea. So, so in summary, irregular bleeding can be everything. If the bleeding can be excessive, as is called as heavy menstrual bleeding, or the bleeding can be less, or it is bleeding is absent for a few months. The reasons of two are entirely different. The bleeding is excessive occurs for a few reasons, and bleeding is less or absent occurs for a few other reasons. And also we have an entity known as unscheduled bleeding. The bleeding between the cycles, that the bleeding is normal. Every month the menstruation is normal, but some unscheduled bleeding is happening between the cycles. And bleeding after sexual relation or bleeding after menopause, that means you are around, some women come this presence that I'm 60, that she is 60 years of age, that the bleeding has stopped for about 7 to 8 years at 52 years of age, and she's experiencing some bleeding or abnormal bleeding or heavy bleeding, or it is mild bleeding also. The volume doesn't matter, but whether there is bleeding present or not after menopause. That after menopause, if there is bleeding, there is obviously an irregular bleeding, or sometimes this is abnormal bleeding. Few things I like to highlight about puberty and this adolescent age group, that 12 to 19 years, that some parents are very agitated and they present with OPD with the child, that there is a variable menstrual pattern. There is sometimes episodes of what we say in medical terms, it is amenorrhea. That means absent menstruation for 3 or 4 months, and there is sometimes heavy bleeding. So this is absolutely normal. So we have a axis known as the signal comes from the brain, and that hormone through bloodstream that acts as a signal for the ovaries, and the ovaries secretes some hormone, estrogen, that acts on the uterus, and that's how the bleeding happens. So this cycle takes a few years for maturation. That if the menstruation starts at 12 years of age, and initially after menarche, what we say the initial menstruation, that is known as the menarche. After the menarche, it is not that every month it will have a regular menstruation. This axis, as I mentioned, that from the brain to the ovaries and then to the uterus, this signaling and all these things takes time. So maybe a few years. So that time, the episodes of amenorrhea is absolutely common. There is not any need of any treatment. Sometimes that happens that there is heavy bleeding. Obviously, that can be managed with few oral medication, but it is severe. Sometimes it happens. So if it is severe, then it requires some treatment and investigations. So before proceeding to the causes and the relevant investigations and management, I'd like to just a basic uterine anatomy for the proper understanding that this is a uterus, and this is the main part of the body of the uterus. And this is the cervical part, what is the front part of the uterus. And these are, of course, the ovaries and the tubes. So mainly the bleeding happens because of the reasons of any pathology of the uterus, this part which is mentioned also in the picture. And sometimes the bleeding happens due to pathology of the cervix, which is also mentioned in the picture. So the reasons, the pathologies are different, but everyone presents with a abnormal uterine bleeding. So I will be coming to the causes. First, I like to mention few of the causes of heavy menstrual bleeding. Heavy bleeding occurs, as you are all aware, that uterine fibroids. Uterine fibroids are the most common causes of the fibroids, though in majority of cases it is asymptomatic, and every fibroid doesn't require any treatment. Those are small fibroids, asymptomatic ones, is not treatment, but few majority of the fibroid cause symptoms, and the most common symptom is a heavy bleeding. And also is an entity known as endometriosis, which is known as the chocolate cyst. And the chocolate cyst is a disease of the cities. So cities means you are having only one child. There's a history of infertility. Then endometriosis happens. So endometriosis causes a different clinical the picture. Means a number of clinical feature, means that it can cause pain during this menstruation, and also heavy menstrual bleeding, and also it can cause infertility, and also it can cause pain even after the menses also. So it has a number of clinical features, and out of these, a heavy menstrual bleeding is one of them. Uterine polyps is also a very common cause. Sometimes the infection of the uterus, what we call as a pelvic inflammatory disease. The patients usually present with fever. Patients can have, women sometimes have features of lower abdominal pain and white discharge, and associated with that, she may complain of heavy menstrual bleeding. Uterine cancer is definitely an important cause. It is a cause for the elderly woman, means after menopause. Majority of the age group is 50 to 60 years. So obviously, it is more common if as the age advances. And one thing is the most important cause is abnormal pregnancy. Abnormal pregnancy is also very important cause. Any woman presenting with an abnormal bleeding, that bleeding may not be that is a heavy bleeding. It can happen that the patient is presenting with a just spotting or any bleeding entire month, or there is a heavy menstrual bleeding at unscheduled time. So abnormal pregnancy needs to be ruled out. It is an important cause of bleeding. Next, I will be coming to some systemic causes. Of systemic causes means it is not related to uterus or ovaries. It is related to any medical condition that is causing some abnormal bleeding. It can happen due to coagulation disorders, that the blood thinners, medicines like aspirin or warfarin you are taking for any cardiac issues, or after some cardiac surgery, then these drugs are prescribed. So if there is some overdose, it can present with heavy menstrual bleeding. Sometimes there is diseases of liver and kidney. There can be history of jaundice, and after that there is chronic liver disease. And there is so these also patient can present with heavy menstrual bleeding, and also hypothyroid condition. Condition, this is one of the commonest causes. that any patient presenting with abnormal bleeding, a thyroid profile is a mandatory. In many cases we get the abnormalities of the thyroid, the hypothyroid or is hyperthyroid. So estimation of the TSH is a very important part of the evaluation of a case of heavy menstrual bleeding. Sometimes, in spite of all investigations and relevant blood tests and ultrasonography, we don't get a definite cause. So that time we say the DUB. DUB means dysfunctional uterine bleeding, where there is a no definite cause. All the causes are ruled out. It is mainly because of some hormonal imbalance. And the signaling which I mentioned that comes from the brain to the ovaries, then to the uterus, is a disturbance of the axis. It can happen because of any stress factor, maybe physical stress. Sometimes it is a mental stress. It can happen. That is, no. Sometimes the menstruation is delayed, and the menstruation can happen after a few months. But sometimes there is heavy bleeding. So if there is no definite cause, you can tell it a dysfunctional bleeding. Now coming to it is the uterine fibroid. Uterine fibroids is the most common tumors of the female genital tract. As majority of the cases, if there is a ultrasonography done on 50 or 100 women, everybody will have fibroids on ultrasonography. But every fibroid doesn't require any treatment. It depends on the size and the location of the fibroids. As it is shown in the picture, the some fibroids are towards the inside of the uterine cavity. And some fibroids are very large, and some fibroids are towards the outside part of the uterus. So every fibroid doesn't require any treatment, but if it is very large or if it is causing very severe bleeding, then obviously there are medical methods also, as well as conservative methods also, that is removal of the fibroids and preserving the uterus. And if the symptoms are severely resistant to medical therapy, then we can go for hysterectomy, that is removal of the uterus. So it is one of the commonest causes, and it is one of the common causes of the irregular bleeding or heavy bleeding. Risk factors when there can be obesity, and sometimes it is genetic factor. Hormonal factor is obviously a factor. Nulliparity. Nulliparity means with a history of infertility or only having one children or no children. So they are more prone to fibroids. So next, the condition is adenomyosis. Adenomyosis basically, as shown in the picture, the uterine wall is infiltrated with some blood where it comes from the uterine cavity. As shown with the normal uterus, the uterine musculature is normal. And in the abnormal part is shown in the picture, there are a few bloods which has entered into the uterine muscle. So it can happen because of any uterine trauma. Trauma can happen during normal delivery. It can happen after cesarean delivery. It can happen after repeated medical termination of pregnancies. Like someone may having 2 or 3 abortions, or then they are more prone for this disease. And any type of uterine surgeries. The cesarean section is also a type of uterine surgery. And other types of surgeries which require the removal of fibroids, so preserving the uterus. So these patients, these women, they are more prone to develop adenomyosis in future. So I have dealt with the causes of heavy menstrual bleeding. Now I will be focusing few of the causes of absent or less menstruation. So one of the most common one of the most common symptoms, or you can say, or the patient presenting with an ultrasound diagnosis, it is one of the very common ultrasound finding you are having a PCOS, the polycystic ovary. The polycystic ovary is a very common cause of absent or it is less menstruation. As I mentioned before, also hypothyroid condition is also an important cause. Sometimes we find a raised prolactin level. The raised prolactin level, it is a hormonal. Liver prolactin is a hormone which can elevated due to a number of reasons. The most common reason is taking repeated antacids. We have a receptor inside our body that alters because of taking antacids, and that is why there is a raised prolactin level. And also, obviously, there are few of the diseases like if there is liver failure or if there is kidney failure. But apart from antacid, there are some antipsychotic, like for any psychiatric condition or like depression. There are a few medications which also causes raised prolactin level. So raised prolactin can cause absent or less menstruation, and also physical or mental stress and can cause absent menstruation. And few of the less important and the rare is the endometrial tuberculosis, the tuberculosis of the uterus, that can sometimes cause a very rare cause of absent menstruation, that is known as oligomenorrhea. And sometimes it is physiological, that some may present in OPD that there is no bleeding for about 6 months after delivery. That there is no bleeding about 6 months after delivery. There's some then it happened, and then the bleeding happened for 1 month, and again there is amenorrhea, that is no bleeding. So during breastfeeding or after delivery, it is common. So it is also because of that hormone, these raised prolactin levels. It is expected that the periods will be like this, so there is not much of concern during breastfeeding if this is the type of menstrual pattern. After menopause also, there is a complete absence of menstruation, and sometimes during adolescent age group, as mentioned before also, that the side that uh, this entire axis of the how the menstruation happens, for maturation it takes a few years. So immediately as the menstruation starts by 12 years or 13 years of age, for first 2 to 3 years, if the menstruation are not regular, it happens like this, that there is absent for 2 to 3 months, and there is menstruation for 2 months, and again there is stoppage. So PCO I will discuss in detail. So since it is one of the most common the presentations in OPD, PCOS is basically an endocrine imbalance. Endocrine imbalance means it is a hormonal imbalance, and the commonest feature is amenorrhea. Amenorrhea means no menstruation. And the clinical entities, usually some features are obviously associated. Obesity is one of the important feature which is associated with PCOS. And as is shown in the picture, it is acne is present, and also excessive hair growth or excessive hair growth on the face or abnormal locations. It can be on the cheeks or it can be any part of the body. So obesity, excess hair growth, and acne as a most of the important features of the PCOS, and it usually exists together. And the main pathology, as I mentioned, the hormonal imbalance, it causes insulin resistance. The patients are more prone to diabetes, and because of fat, and there is also an androgen excess, the male hormones. So that causes an excess hair growth over the body, and also features of acne. So the main central pivotal role is obesity. If we can treat obesity with a number of interventions, lifestyle modifications such as walking, and also dietary modification and exercises, if we can optimize, if women can optimize the weight, the PCOS and this absent menstruation or amenorrhea can be treated. And then the point is the unscheduled bleeding, that is bleeding after sex or between the cycles. It usually happens because of any cervical pathology. Cervix means, as shown previously shown in the picture, cervix is the lowermost part of the uterus. The lowermost part of the uterus, that any polyps on cervix, or if it is cancer or it is infection of the cervix, can cause bleeding between the cycles. What we in medical terms we say that intermenstrual bleeding. And also women who are on long oral contraceptive pills. Long oral contraceptive pills can sometimes causes unscheduled bleeding. What we also say as breakthrough bleeding, that between the cycles sometimes the bleeding happens in spite of regular menstruation. So oral contraceptive pills as a important cause. This history needs to be ruled out, that whether she is taking any oral contraceptive or any hormonal medications. Sometimes it happens that irregularly she is taking any like hormonal, she is taking hormonal medication for 5 days, then then she is stopping the medications, and again she is restarting. So after she takes the medication for 5 days, then after stoppage, there is expected a bleeding will happen, that is known as withdrawal bleeding. So the hormonal medication needs to be taken in a proper regimen, that we have a 21-day cycle. Sometimes we prescribe for 24 days. So this regimen must be maintained. That not that it is taken for 5 days, then someone can stop and again to restart that hormonal medication. Then this withdrawal bleeding, again hormonal medication intake. This will continue as a vicious cycle. So the regimen is very important. Then is a postmenopausal bleeding. Postmenopausal bleeding, as I mentioned before, also uterine cancer needs to be ruled out, or any hyperplasia. Though it is a less common cause, about 10% of postmenopausal bleeding is due to cancer, but this needs to be ruled out with a proper biopsy and proper ultrasonography and other evaluations. Sometimes there is uterine polyp which can cause the postmenopausal bleeding, and also endometrial atrophy. Because of age, sometimes there is atrophy. That means there is dryness of the uterus. So that can cause sometimes an unscheduled bleeding, a postmenopausal bleeding. So till now we discussed with the types of bleeding, that the heavy bleeding, or it is less bleeding, or sometimes it is unscheduled bleeding. And we have also discussed the causes of the bleeding, that what causes the heavy bleeding, what are the reasons for less bleeding, and what is known as unscheduled bleeding. Now we come to the management part. The management part comes with the starts with age and the detailed menstrual history. Like age, as I mentioned before, sometimes the adolescent age, the episodes of amenorrhea, that is absence of menstruation, doesn't require any treatment. Detailed menstrual history is important, that maybe it happened that the last menstrual period is 1 or 2 months back. Then there can be chances of abnormal pregnancy. Obstetric history means the delivery date and the breastfeeding status. The patient may present with like absent menstruation, or there is irregular bleeding, or she may give a history of breastfeeding, or there can be a history of delivery date 3 to 4 months back. So then the women can be reassured that this is the normal pattern. Medical condition, as I mentioned before, also like liver diseases, kidney diseases, patient with cardiac surgeries or some cardiac conditions, they are taking some blood thinners, then that can cause abnormal bleeding. Hormonal medications like oral contraceptive pill can cause abnormal bleeding. Any family history of cancer is also important. Like sometimes there is a, for uterine cancer or ovarian cancer, there is a strong family history. Though in less, it is about 10% of cases, but there may be a history of the familial breast and ovarian cancer. There can be a history of breast cancer or ovarian cancer. Then we have to be more cautious. Symptoms of anemia. Whenever there is bleeding happening, there will be, and specifically if there is heavy menstrual bleeding. If there is heavy menstrual bleeding, there are symptoms of anemia if it is severe. Like there are examples that patients initially presented with just unconsciousness, like the sudden history of blackout, and sudden history of blackout, and ECG was done along with CT scan, brain for evaluation. Then ultimately it came out that the hemoglobin is very low, and then then the woman revealed that she has a history of heavy menstrual bleeding for a few months or for a few years, and that caused a decrease in the hemoglobin and all the subsequent clinical picture. So investigation, obviously hemoglobin percentage is very necessary. What is the current hemoglobin status, and whether it is corroborating with uh, the bleeding pattern with which the woman is complaining. Coagulation profile, sometimes there is altered coagulation profile, that the blood is not able to, there is no proper clotting of blood. This is specifically in adolescent age group. We have some coagulation disorders such as von Willebrand disease present in adolescent age groups. So that is a very important factor, specifically in adolescent age group. Though in adults also we test sometimes when there is a bleeding manifestation, that there are bleeding spots, rashes over the skin, or there is a history of abnormal bleeding during any previous cut wounds or like that, you obviously test some coagulation profile. Liver function test, kidney function test are required. TSH, prolactin, and other hormonal evaluation, and urine pregnancy test. Like as I mentioned, any woman presenting with a heavy bleeding, the pregnancy needs to be ruled out, because there are always possibilities that there is an abnormal pregnancy which is causing a heavy bleeding. So now we come to the imaging part. The transvaginal sonography is a single most important evaluation with which we can categorize the in what direction we'll start our treatment, and whether it is a fibroids, as I shown the picture before, or it is adenomyosis, or whether there is a chocolate cyst, or whether it is a polycystic ovary, or whether it is an abnormal pregnancy, or whether there is a chance of uterine polyp or a raised endometrial thickness in postmenopausal bleeding. So basically, it is a for further management along with history. It requires a proper direction. It gives a proper direction that where to in which direction the management will progress for curing and further investigation of the abnormal uterine bleeding. Rest is a CT scan abdomen. MRI, it is not used routinely, but if there are large fibroids or any suspected malignancy, we can obviously use. Hysteroscopy, it is basically an examination of the uterine cavity with a camera. So the main important point is this is a diagnosis as well as treatment is possible at the same time. Examination of uterus means is as is shown in the picture, there is a camera which is inserted inside the uterus, and we can have a good view of the inside of the uterine cavity. So if there are polyps, we can remove at the same sitting at the time of diagnosis only, and the patient will be cured. Sometimes it is submucous fibroid, that is fibroids more towards the inside of the uterus. So we can remove the submucous fibroid at the same sitting. And treatment is obviously done along the same sitting, diagnosis and treatment. And sometimes we take an endometrial biopsy. That there is indeed there are some specific indication, like if it is postmenopausal bleeding, like bleeding at 650 after menopause, like 55, 60 years of age. And there are some risk factors for cancer, like obesity, patient is diabetic and hypertensive. And in spite of there's no response with medical treatment, like hormonal medication prescribed for a year or 6 months or 8 months or 1 year, but still it is not responding. For then we can do a hysteroscopy to detect any polyps or any fibroids or some uh, other pathologies which will present inside the uterine cavity. So hysteroscopy is a very important part of the evaluation. So now coming to the treatment part, as I mentioned before also in the start of the presentation, that identification of the normal menstrual pattern is very important. Like what is the cycle length, sometimes what is the flow volume, what is the duration, and it is a regular or not. So some women complains of that is irregular bleeding, but they are not aware of what is the normal pattern or what is the normal range that the bleeding, the duration the bleeding must occur. So when we say that, like to inform them regarding the normal pattern, that this is a normal volume, this is a normal duration, and this cycle, everything between 24 to 38, everything is normal. So when they maintain a diary or a calendar, like from the month of March, this date, April, May, June, July. So ultimately they feel that it is a normal menstruation they are having. So in many cases, this is the only treatment. Coming to the medical methods, so we have many options of non-hormonal, hormonal medications we have. Non-hormonal, we can start with a few tablet. Pause is mentioned is tablet tranexamic acid. For for initial cases, we can give a trial with the non-hormonal medications. And if it fails, we can go for hormonal medication like oral contraceptive pills. We can also give progesterone tablets. And proper regimen is mandatory. Like as I mentioned before also, it is not that you take it for 5 days, then stop and again is take for 5 days. It is not like that. It has to be taken in a proper regimen, like 21 days, then a gap of 7 days, then again for 21 days, like this. Next, it is a type of medical management. It is known as the levonorgestrel intrauterine system. It is basically a hormonal copper T. Hormonal property means, as shown in the picture, it is different from the previous property. It comes in an inserter, as it is shown here, and it is a special, that is a cylinder. There is a hormonal load loaded inside. It is 52 mg, which works for about 5 years. So it is inserted inside the uterine cavity as shown. So the advantages is that it is a type of basically a medical treatment, but it is, you require a no oral medications, and since it is inserted inside the uterus only, the side effects are less as compared to oral medication. The oral medication, sometimes there is, for after repeated long term, or the oral hormonal medication, sometimes there is raised liver enzymes, or there is a feeling of nausea and vomiting, and the weight gain. So all these side effects are very less, and it is 90% the response rate is present. Means in 90% of the cases the bleeding reduces, and it is effective for 5 years. And it avoids hysterectomy, and it not in every cases it is not needed to remove the uterus. So without removing the uterus, or without taking it is a very cumbersome to take oral medications for about 5 to 6 years. Then to avoiding this also, the bleeding, so there is a 90% success rate with this levonorgestrel intrauterine system. And obviously there are advantages of less cost. Obviously there it comes with a few disadvantages, like initial 3 to 4 months you need to take some hormonal medications for some combating some irregular bleeding, and sometimes there is expulsion. Though the rate is very low, this property is it comes out. So if it comes out, then the treatment fails. So basically these are, but though the percentage is very less, about 1 to 2%. So as per the current protocols and guidelines, there is a first line of management of heavy menstrual bleeding. So obviously we cannot apply the levonorgestrel intrauterine system, what are shown is Mirena, in every case. But if the fibroids are small, less than 4 centimeter, or if there is DUB, that there is uterus is normal and there is no obvious cause of heavy bleeding, other hormonal profile and other medical condition ruled out, and with adenomyosis, then obviously this levonorgestrel intrauterine system can be used. Surgical method, we have a conservative surgery, a myomectomy, the removal of only the fibroid preserving the uterus, and also hysterectomy means the removal of ovaries. Obviously these we must go a stepwise. Initially we must try with hormonal, non-hormonal medication, then to hormonal medications, then if it doesn't respond, then levonorgestrel intrauterine system, and absolutely the candidates not responsive to any of those, or with big fibroids. Very big fibroids means a size around more than 10 centimeter or 8 centimeter. Very large fibroids or ovarian cysts, that is a hysterectomy, may be the treatment option. And for whenever we go for surgery, minimally invasive surgery is obviously suggested. Laparoscopy for benign cases, for fibroids, ovarian cysts, adenomyosis, and the new advances is the robotic surgery for if there is history of if the malignancy is detected, such as uterine cancer, cervical cancer, etc. So advantages are, it is less blood loss, and it is small scar and early return to work, because of it is less pain. It is obviously less painful when you have a large cut over the abdomen. It usually minimally robotic or laparoscopic surgery usually have small holes, like small holes about 5 mm, and sometimes in a 10 mm. So 1 centimeter or 0.5 centimeter are the holes present over the abdomen. So obviously there will be less pain and early return to work, and there will be less blood loss and a small scar and less hospital stay. That is also important, because the more the chance of hospital stay, there will be chances of wound infection in an open surgery. So all these are all the advantages of minimally invasive surgery. Now all these are treatment of heavy bleeding. If you are coming to the absent or less menstrual blood, the commonest cause is PCOS. So PCOS, the single most important factor is weight reduction. Whatever treatment modalities are there, it only it is effective if there is weight, if the obese patient, if she reduces her weight to an optimal level, even the 10% reduction of the current weight means some woman is 75 kgs. It is not that the weight absolutely must be 60 kgs. From 75 kg, if she manages to at least decrease a 5% of weight, about 70 kg, that will be helpful to correct the menstrual abnormality. It reduces acne and excess hair growth. And associated it, there is altered TSH and prolactin level that needs to be corrected. And with this, we also give some hormonal medications, and we also give a metformin therapy. But the weight reduction is the single most important part of the management. So we coming to the take-home message to be aware. First point is obviously to be aware of the normal menstrual pattern as per age and other situation. Like from adolescence, some menstrual pattern is absolutely normal, and after menopause or after breastfeeding, some pattern, as I mentioned, it is normal. And to be aware of the normal pattern and to consult a doctor when there is an abnormal pattern of menstruation. And after consultation, identification of the cause, like it is just removal of the uterus or treatment or the remove a fibroid is not only the solution. It may be happening that you are taking some drugs like aspirin, warfarin, that is causing the heavy menstrual bleeding. So only removal of uterus, so they identify the proper cause, whether it is a local cause like related to uterus or ovaries, or it is something related to other medical condition. Initially, we must go for a medical management and correction of anemia if present, and LNG IUS, as I mentioned, to be tried whenever feasible, not in all cases, but whenever there is a appropriate indication. And when surgery is indicated, minimally invasive surgery always be the choice, because of the advantages I mentioned: less scar and less hospital stay and less pain and less blood loss. Thank you.
Thank you so much, Dr. Ganguly, for that comprehensive, a very comprehensive look at the most common causes of, irregular periods and bleeding, whether irregular bleeding.
Yes.
So I guess the question is, you mentioned when the patient should go consult the doctor, right?
Yes.
So I guess the question is, and please, if anybody in the audience would like to ask a question, if you're on Zoom, please put your question either in the chat box or raise your hand, and we'll try to get to your question. When should a woman seek attention? Like, how many cycles should she wait for with irregular bleeding or with irregular cycles before she says, I need to go to the doctor now? 1 cycle, 2 cycles, 3 cycles. And I guess, because when we were in medical school, we learned the most common cause of irregular cycles. One of the things you need to rule out is pregnancy, whether the patient is actually pregnant or not.
Yes.
So what do you think about that, sir?
The cycles means what the criteria which I mentioned, that initially 2 or 3 cycles women can wait, because initially sometimes it happens that there is some like excess menstruation, what we say the heavy menstrual bleeding for 1 or 2 cycles. That may not be significant. So one needs to wait at least for 2 or 3 cycles. But obviously there are individualization of situations. Like sometimes it has happened that a woman presenting in the hospital with a very severe vaginal bleeding with menstrual bleeding for 10 to 15 days continuous. But as per the patient, she was having normal menstruation for 6 months. So obviously, for 2 or 3 months, obviously she can wait that whether the menstruation is returning to normal or not. But if there is severe bleeding in the sense that you are requiring to change, if we have a criteria like to change pads 1 hourly or 2 hourly, and in a day you are requiring about 11 to 12 pads in a day, then obviously in that first cycle only she needs to seek a medical attention.
Perfect, sir. Which I guess you kind of answered my next question I was going to ask, which is, as a woman, what would most women consider, because they don't know in ml, right? We say 80 ml of bleeding, they do not know how to figure that out. So I guess how many pads per day, or what is the equivalent of how much blood is there in 1 pad usually before it gets soaked?
So normally the recommendation we have that I mentioned in the slides also that it is not every time it is not possible to measure in ml, but
Correct.
if it is a 4 to 5 is a standard guidelines. Like if a woman is changing pads around 4 hourly or 6 hourly, so 4 to 6 hourly, that means in a 24 hours it is coming around 4 to 6 pads in a day. So that is normal. So always for taking a history regarding heavy menstrual bleeding, we ask a few questions like how many pads you are using. Somebody, if she is telling that I need about 10 pads in a day, I also need to change the pads at night also. And there is passage of clots. As a clots means there is with about 10 pads in a day with changing required to change pads at night. That is symptom of heavy menstrual bleeding. So measurement in ml is not possible, but these are the almost we take a ancillary markers of asking that whether she really has a heavy menstrual bleeding or not.
Excellent, sir. Thank you. And I guess I do not see any questions from the audience. I'm just going to ask one final question and then we'll call it a wrap. This is regarding menopause. You know, a lot of elderly women out there, they start feeling the symptoms of menopause or what we call perimenopause, the hot flushes. But you know, when does menopause actually kick in, and when can you consider yourself, I am now actually menopausal or post-menopausal? What's that definition?
Menopause is always a retrospective diagnosis. Retrospective diagnosis in the sense that patients, it usually happens that the menopausal bleeding, the menstrual bleeding stops in 3 ways. Some women have that bleeding stops, having normal menstruation for last 6 months. Suddenly the next cycle, the bleeding stops. Some women, they have the pattern that the bleeding is gradually stopping and the volume is decreasing over a period of month, then it is stopping. And some women, they have a clinical feature of there is some excess vaginal bleeding, excess menstrual bleeding over 2 or 3 months, then gradually it stops. So, and the symptoms of hot flushes can be present during these years, during the menopausal time. But absolutely, just to diagnose the whether menopause happens or not, it is retrospective. Means after the menstruation has stopped for 12 months, then we can say that obviously that she has attained menopause.
Okay,
Before we
perfect.
cannot predict, we cannot predict like that when she will be having her last periods.
Excellent. So basically, if the medical definition that we as doctors would tend to use is at 12 months of no
12
cycle or no
months.
bleeding, is then we've said that menopause has occurred. So you
Yes.
cannot predict it. You have to tell it ho gaya hai, ab ho
Okay.
chuka hai.
Ho chuka hai.
Correct. Okay. Excellent. Thank you, Dr. Ganguly. Thank you to our audience for being such patient listeners. We have covered a lot of topics today, a lot of very, very important topics today. In India, at least among women, um, dysfunctional uterine bleeding or irregular bleeding or heavy bleeding is the most common cause of anemia, which in women is the most common cause of them not being able to do their regular work, doing household activities, raising kids, going out. The most common cause of anemia in India right now is a insufficient iron intake, and another very important cause is heavy bleeding or irregular bleeding. Cervical cancer is among the most common forms of cancer in women, and it is one of the few types of cancers that is actually 100% preventable by appropriate vaccinations at the right age. All of these, what do they have in common? Bleeding, right? So if you are having irregular periods, if you are having heavy bleeding, if you're having low bleeding, please do not ignore it. We have a lot of specialists at Medica, including experts like Dr. Ganguly, who are here, who's their life's work and are available to help you. I'd like to thank Dr. Ganguly for making an extensive presentation, a very well detailed presentation and explaining it so well. And once again, as always, I'd like to thank Medica's IT team for helping to host this seminar and webinar on Facebook and on Zoom. And as always, our marketing and branding team, along with the Rotary Club of Aviana, for help co-host this event. As always, health is the ultimate wealth. We will see you every Saturday, 5:30 to 6:30 p.m. I hope you all have a good weekend. We have a tropical depression here in Calcutta. It's raining quite heavily. So I hope you're all safe, and I hope you have a great day ahead. Thank you so much, everyone. Thank you, Dr. Ganguly.
Thank
Thanks.
you.